Hello, everyone. Good morning, good afternoon, good evening, wherever you are, whatever time it is where you are right now. Dr. Hess here with a quick overview of our chapter 7, which is the mood disorders, and we'll talk a little bit about suicide prevention and treatment. Hope you're doing well, keeping up on the discussion boards, checking our syllabus for our quizzes and when our assignments are due. Most of you are doing great. Good job. Thank you very much. Let me jump right into our lecture so we can keep this as short as possible for us today. Let's see here. Here we go. All right. This is mood disorders. So let's talk a little bit about probably the most common mood disorder is depression, followed by probably anxiety and worry, but depression is probably something that all of us will experience at one time of our life. Whether it'll reach the clinical depression level where we will need treatment depends on how what kind of support we have and how we're what kind of resilience we have to the losses that life brings us. There's lots of changes that happen to us when we're feeling depressed. Our mood is low. We sometimes will lose our appetite. Sometimes we'll be eating more. We'll have some sleep disturbances. We might be sleeping more or sleeping less. And a lot of times our activity level will be really low if we're having depression, a mood depression where we're feeling lethargic. If we're having an anxious depression, which is very common, oftentimes our activity levels will increase. Our productivity does not increase, but we tend to be moving around more and doing that. We are often feeling feelings of worthlessness. In other words, that we don't have anything to offer. We often feel guilty. We're not sure exactly why we feel guilty what we've done wrong. We often will feel hopeless, that there's nothing that can change. One of the voices of depression is usually that things will always be this way and it'll never get better. And sometimes if this lasts long enough, we will start thinking about, that life is really not worthwhile and that we might want to contemplate ending our life. One of the other side effects of depression is an inability to concentrate, which is hard for students because we need our concentration to be able to read and study and learn. All right, let's keep going. Major depression disorder. Okay, so now we're back into the DSM-5, that Diagnostical and Statistical Manual of Mental Disorders put out by the American Psychiatric Association. Has different levels of depression that you can see on the screen. If you're interested in this, you can take a look at the DSM online and just Google DSM-5 and you'll major depression disorder. Seasonal affective disorder is something we up here in the Pacific Northwest are very familiar with. This is where we experience major depression episodes seasonally. In other words, when the clouds come and we don't get some sunshine, some of us are prone to depression at that point. A lot of us have, these therapy lights that will help with that. Others of us get out and drive to some sunshine for a while. But SAD, or seasonal affective disorder, is quite prominent in a lot of areas that have cloudy, cold winters. Postpartum, I'm sorry, peripartum is the what is now called the old postpartum depression. After a pregnancy, sometimes women will experience severe depressive episodes with the fluctuation of the hormones after birth and with the changes in their life and the responsibilities. Oftentimes become overwhelming and can cause some problems. A lot of women will have high emotions and after birth, but doesn't quite meet the criteria for postpartum depression. But there it is. We have all of these different types of depression here that we have. You can see lots of different ones here that there are subtypes of our clinical depression. The young adults that are transitioning through the stages of adolescence into adulthood are prone to depression. Some children are prone to depression also. Depression in children sometimes the symptoms will be something like some kind of bodily symptoms, stomach aches, irritability, anger issues. Oftentimes are the way children express their depression. Older seniors, people over 65 are prone to depression. Oftentimes, this can be due to medications they're taking or just the life stage that they're in, having a series of losses late in life, or just retirement can cause a loss of meaning, and a depressive episode can occur. Well, let's keep going. Okay, so in the mood disorders, we have depression, which is that low mood. Mania is a high mood, elevated feelings of grandiosity, really racing thoughts, rapid speech, and impulsive actions are the main characteristics of mania. We see mania in bipolar 1, where we have these symptoms. In bipolar, we have both depressive symptoms and mania symptoms. Bipolar 2 has severe depression, but doesn't quite meet the criteria for mania. Cyclothymia is kind of a chronic bipolar condition. It's less severe. Some people call it bipolar light, but it is a mood disorder that is the up and downs throughout a person's life. Here are the graph for that. We have, again, different subsets of bipolar, which you can read about in our book. And again, I'm not trying to make these lectures exhaustive, and I know some people are wanting more from the lectures, but I'm just trying to give you an overview so that you can do your own research and your own reading as we go along. And so I know that sometimes these are not as satisfying as people would like, but it's done on purpose for a reason, trust me. Okay, back to our lecture. Let's see, here we go. So what are the biological theories about depression? Why do we get depressed? There are, of course, the genetic theory that some people are predisposed because of the genes and the chromosomes that we inherited from our parents and their parents and their parents predisposes to depression. We have a lot, especially nowadays, an emphasis on neurotransmitter theories where something goes wrong in our neurons, the communication between neurons at the synapses by these neurotransmitters, most specifically serotonin, but also norepinephrine and dopamine. Some of us are prone to it because of structural or functional brain abnormalities. Something is changed in our brain, or something is not formed correctly in our brain, and we are prone to depressive moods. Let's see. Also, we can be prone to depression because of our endocrine system. Some of our hormones dysfunctions can cause depressive moods in our body and in our mind. There we go. There's the synapses I was talking about, and that communication between one neuron and the next. Here's our brain, some of the different things we have about that. The psychological theories or the cognitive theories of depression. So now we're not thinking about the biology of the body, but more of our thoughts. There is some learned helplessness theory is that some of us experience life and we try really hard and we fail, and some other times we don't try at all and we fail, and we come to the conclusion that no matter what we do, we fail, and so we feel helpless. We feel like we have no power in the world, and that leads us to be depressed in that. Let's see. Some of us are really sensitive to rejection, and rejection is part of life. Most of us have learned that in our dating times, or if we're dating right now, you know that rejection is part of life. Not everyone is going to like us, but some of us are really sensitive to that, and depression will follow a series of rejections or abandonment. Let's see here. Oh, damn, keeping going here. So I'm sorry, let's go back to biological treatments. So drug therapy is probably the most common treatment for mood disorders. And most of our antidepressants are somehow affecting our neurotransmitters, probably serotonin, the selective serotonin reuptake inhibitors, the Prozacs, the SSRIs, as they're sometimes called, are kind of the most used right now. We have mood stabilizers for bipolar. Lithium, which is a heavy metal, has been found to be helpful in treating that, along with some antipsychotic medications and anticonvulsive medications seems to help stabilize the mood of people who are experiencing bipolar. Electroconvulsive therapy is been much improved over what we see probably in the movies. This is where we stimulate parts of our brain with electricity. Well, the doctors do, we don't do it. The doctors stimulate parts of our brain in order to kind of restart our brain chemistry in a way by giving it this electrical thing. We have magnetic stimulation now. We use strong magnets around our brain, and this is found to be helpful in changing our moods. There's lots of different things, and light therapy I mentioned before that was been found to be effective in treating seasonal affective disorder. The psychological treatments continued, excuse me, the behavior therapy. This is changing our behaviors. Oftentimes with the help of a counselor, they can suggest that we do things like eat differently, exercise more, get out, be more social, getting new skills on interpersonal relationships can be helpful. Also, cognitive behavioral therapy, probably the most common treatment for depression in the talk therapy world, counseling world, is dealing with the thoughts and the behavior. So your counselor is exploring your negative self-talk, the way that you are maybe ruminating about certain things, and challenges those thoughts and helps you replace them with a more positive thought. Let's see. Okay, let's go here. Again, I think I'll add in here that probably the most important thing about counseling is the relationship between the counselor, the therapist, and the person. So if you really feel like your doctor is on your side and wants you to get better, you'll have a better treatment outcome. Let's see. Let's talk a little bit about suicide. There's a lot of people who attempt suicide, and the people who actually complete suicide are the people that actually end their lives. It is very common to have what they call suicide suicidal ideation. And these are thoughts of suicide, things like, oh, I think it would be better if I wasn't here. Everybody would be more happy if I wasn't here. If I ended my life, I would end my pain. I can't take it anymore. All of those kind of ideation kind of things, thinking about ending your life is common. I think most people, if they're honest with themselves, have contemplated those thoughts. But again, not that many of us will attempt or complete suicide. Let's see here. There's some of the stats about suicide. Older men are at high risk of suicide, and the reasons for losing a spouse and having some kind of illness. College students are also at high risk because of the challenges of the transition from high school to college and the emphasis on social interactions and conflict with parents, individuating from your family of origin, finding out who you are can often leave students feeling adrift and not really have the anchor that they need to keep going. Let's see. All right, keeping going here. So what are the risks of suicides? Of course, depression. That's why we have it in this chapter. Bipolar has a lot of people who are living with bipolar disorder have a lot of suicidal attempts and completions. Any past suicidal thoughts, or if someone in your family has attempted or completed suicide, your risk of suicide goes up. So want to go like this. Let's keep going. Treatment, basically hospitalization is probably the best treatment for people who feel like they might want to harm themselves. There's again, reaching out to your family doctor or counselor for medication or just counseling, again, is really helpful in this. There are suicide hotlines everywhere. Just Google that and you'll come up with it. They are usually manned 24/7 with someone who you can talk to about what you're thinking about. And let's see here. Let's keep going. There we go. We are at the end. Let me bring us back to here. So thank you for being with me for a really quick overview of Chapter 7 for mood disorders and suicide. I will see you in our next chapter. Bye for now.